and the need really to accelerate a digitally enabled supply chain. What I want to start with today is position supply chain within digital health ecosystems. We have delivered a number of webinars on digital health, what it is, and where and how it advances care in healthcare in terms of efficiency, effectiveness, and person-enabled outcomes. It's all foundational on the basis of what do we mean and what does HIMSS mean by digital health. And this is our proposed definition. It really builds on the definitions and views and evidence in the literature over a number of months of critical analysis, and much of that work I shared in previous webinars. So for the purpose of today, quick context setting, digital health is all about connecting and empowering people and populations to manage their health and wellness. If you think about COVID-19, we've actually struggled to connect with our populations and provide accurate, clear information on how to stay safe from COVID-19. And of course, we've all seen a number of outcomes of that lack of connectivity. It's also about provider teams being able to digitally connect to their patients, run clinics virtually. Many health systems were able to virtually shift care very quickly to virtual care environments, but did so perhaps hoping that impact and value has been achieved, but I don't think we've seen any evidence of outcomes quite yet. Undoubtedly, we will very soon. Go to the next slide. I'll have a look at where and how does supply chain fit into the digital health ecosystem. And many of you have likely already seen this. Governance and workforce, of course, if you don't have a digitally enabled and competent workforce, then any digital ecosystem will struggle. It's foundational to a digital health system. And governance to ensure data stewardship, privacy, and security is also critical. Assuming that's in place, then you need to some degree democratization of data, which is where interoperability plays a key role. And in the case of supply chain, what we've seen and what Betty Jo is going to share with you is how critical a digitally enabled supply chain infrastructure is in terms of mobilizing data from the product side, sourcing, where it's located, where it needs to be distributed to meet the priority needs and demands for care during the pandemic as we find ourselves today. But mobilizing data is not enough. It's the analytics and the traceability of outcomes that becomes the critical data and knowledge and insights for any health system leader in order to manage a pandemic and the surge in demand that brings us, as well as how it enables that digital connectivity to patients and populations that a health system cares for. So the meaningful connectivity of a health system being able to reach out to people, populations they serve is a hallmark feature of a digital health system. So where does supply chain fit? Well, supply chain is all about that democratization, mobilizing the product data, the utilization of that those products in care at what rates, volumes, and speed, and leading to and tracking outcomes. What is working best for patients affected by COVID, hospitalized, perhaps in ICU, and what is not working as well. So it becomes a critical digital infrastructure in managing a pandemic. I am absolutely thrilled and delighted. If you go to the next slide, I think I might have one more before handing it over to Betty Jo. So in a very mature ecosystem, if you have a highly digitized supply chain infrastructure, which is very much supported by the CISOM maturity tool, what that allows you to do is mobilize data on what products are we using for whom and under what conditions are we getting the best outcomes. So even think about the different types of drugs they're using to manage COVID patients and or oxygen therapies, ventilation. How quickly can you today mobilize that data, understand outcomes for these patients, under what conditions are you getting best outcomes, what conditions are you not getting quite as good an outcome as you had hoped, and that informs decisions around innovating, changing models of care, routines, and pathways to improve outcomes. And the real-time flow of data then informs teams of are those new models, new approaches, whether it's new products, new medications, or both, achieving a better outcome, and for whom are they achieving better outcomes, so that you can then scale it across an entire health system. A health system like Mercy, and Betty Jo Rocchio is the Chief Optimization Officer, which is such a great title, Betty Jo, is one of the very few health systems I've interviewed globally that really didn't face the massive supply shortages and panic and challenges we saw in so many other global health systems, both within US, but also Canada, Australia, Europe, Denmark, Germany, Italy, and so many others. So today I'm thrilled to have Betty Jo join us and walk you through where and how does this clinically integrated outcomes model and strategy really assist and support health systems to advance and manage the extraordinary demands of COVID-19, but just as important, the extraordinary demands that we are likely to see as this pandemic continues to unfold. So with that, Betty Jo, thank you ever so much for joining us today, and over to you.
Great introduction. My title is interesting only because it's a Chief Nursing Optimization Officer, but what that really is a combination of a chief nurse executive of the system, plus I like to say a little bit of informatics and technology sprinkled in to the way we like to function and take care of not only nursing operations, but everything that touches that nursing and patient component. Next slide, please. I just wanted to give you this reference slide. Those of you who don't know Mercy, we have a fairly large footprint. We are across the entire we call it the I-44 corridor, but we are very Midwestern. We are in Kansas, Oklahoma, Missouri, and Arkansas. And if you know anything about what's going on in Arkansas right now, it's probably not the place to be. We are literally exploding with COVID in Arkansas the last week or so. So we are managing through that even as we speak. We have about 35 acute care hospitals, 10 specialty hospitals, one which is a completely virtual hospital where there are no patients, but it is a structure. And we are using that to a great degree right now, trying to manage patients in an office setting and an acute care environment and in the home environment. We have about 259 operating rooms, which we are diligently keeping running through this whole COVID pandemic. And as you know, for operating rooms, we are a high utilizer of supplies. So having what you need to keep those cases going and serving our communities and patients is key. We have about 4,231 licensed beds. We are the 6th largest Catholic healthcare system and about the 20th largest nonprofit healthcare system in the United States. Next slide. So I wanted to talk first a little bit about what a clinically integrated supply outcomes model might look like. We hear a ton today about clinically integrated supply chain. And when I take a look at this tool, in my mind, it solidifies what that actually means, right? Because there's a lot of definitions out there about what that is. But it's really about supply chain infrastructure to support not only system improvement, but also in the time of a pandemic, it actually measures your reaction time and your ability to be able to get what you need to take care of your patients. So this whole pandemic has really highlighted for all of us what that might look like. And so when you take a look at the stages in this tool, from the very bottom at the 0 stage, we have a lot of hospitals today in the U.S. that operate between that 0 and 1 type of reference. There are a ton of inventory and supply processes that are manual. And when I say that, we may be a little bit digitally enabled on the supply chain side, but when you look at the clinical side, of what supply chain looks like behind the doors of an OR, we are largely manual today in most places. There's a supply chain strategy, maybe for distribution, logistics, and procurement, but when you hit that clinical side, there is completely a lack of vision and strategy. The shame here is that when you carry supply chain through to the patient, it provides better outcomes and a better experience for all of our clinical coworkers that have to take care of those patients. So number one, right, is basic supply chain processes are established as a business function for the organization, which usually occurs again on the supply chain side, and I always question it when we hit the clinical side. 2, 3, and 4 are interesting because many people are looking at inventory tracking and automation to take care of supply costs and inventory management. But when you look at what it actually takes to be able to do this in one of our more complex environments, which is that OR setting, it really means a perpetual inventory management system, a true perpetual inventory management system to be able to manage this. And the beauty of it is once you have a perpetual inventory management system, you start to have the capability to be able to perform data analytics on the way you're performing. Without it, when you're manual, most people cannot go back and grab all those statistics to be able to define what analytics look like. And in the face of a pandemic, being able to react to what you need and what you have on hand demands that you're almost at that level 4. And when you look at level 4, it's really integration of those supply chain processes into those clinical environments to be able to link it to patient needs. To be able to react well in a pandemic, you have to be at level 4 in this tool. There's no doubt that speed to reaction and analytics to help you get there, which we're going to look at what we have available in Mercy today, is going to be key to making sure not only you have what you need when you start, but that you're going to be able to sustain with any surges that are coming with this pandemic. Number 5 looks at the supply chain processes being automated and integrated at the point of care. And what this means in Mercy is that we have a perpetual inventory management system, and in our clinical areas, we have a point of consumption system where the clinical provider, usually a nurse in an OR, is consuming supplies that come into that OR, and it's automatically decremented, charged, and placed in the EMR with a single either scan, RFID, however you get it into that record, it is not a manual touch by those coworkers. That's important because you need that automatic consumption and decrement to know your true inventory values, because that is truly what a perpetual inventory management system does for you. In an OR, if you don't have point of consumption going on, you have about a 48 to 72 hour float on products. And in an OR, that would cost Mercy millions if we didn't have that. Number 6 is transparency across the patient journey that supports that automated traceability. So not only are we linking in the ORs, but we're linking in our nursing units, our cath labs, anywhere where we're consuming supplies for that patient. You need to have that happen to be able to have true analytics and true inventory values. And then being able to consume that data in a way, in an automated fashion that talks about how we're linking that to patient outcomes. In times of a pandemic, it may literally restrict your ability to take care of patients. In times where you're just trying to optimize, linking it to patient outcomes helps you on the procurement side and contracting with getting the best prices, because you know your cost of care and you know what it's going to do for your patients on the other side. And then number 7, which is really just a complete picture, and I'm the most honest person you'll ever meet. Mercy is in that 7 category, but we're still working on a couple of functions that I would say would make me feel good about saying, yes, we've completed all the stages and we're exactly where we should be. But it really is that clinically integrated supply chain that enables us to be able to deliver on personalized care for that patient. We trace the care processes and products used in that care and linking it to patient outcomes and being able to prove best outcomes are achieved for any type of population segment. And I would say that's really what we're trying to achieve in Mercy, is linking our data sets and our analytics to not only Mercy patients, but how do we start to contribute to the body of knowledge for population health. And that's where Mercy needs to develop just a little bit. And we're working on contributing to real world evidence that would help some of the researchers really globally be able to tell a full picture on personalized care. Next slide, please. So how do you even get started, right? If you're starting at level 0, working clear up through level 7 seems like a big task. But there are some focuses within the tool after working with it that I can say, pulling it out, these 4 things are key to working through those 7 stages. And really, when you look at the CISOM tool, for me, when I go back and look at where Mercy's been, it's a roadmap, right? It is a roadmap for how you get there. But you can't just give people just a generalized map of the United States, right, and expect them to be able to get to clinically integrated supply chain. This really is the 4 areas that need extreme focus to get on that right roadmap and then get headed in the right direction. This really is the true north. And it lines out to be governance and leadership, predictive data analytics, clinical integration is key number 3, and then automation is number 4. And I would say, starting in any particular order, you have to have the governance and leadership established first. Without that vision and strategy behind where you're going, you will certainly spend more money than you want and end up in a spot you don't want to end up in. And if you're going to spend money, know what your analytics platform is going to look like at the end of it, because you're going to have to measure yourself. So I put that second for a reason, only because you're going to be able to need to measure where you've been and then where you ended up. And showing data analytics, not only at the clinical level, the supply chain level, but then how do you roll it up to the C-suite level to be able to make decisions. And I'm going to show you a data set here in a little bit that I think really solidified in our top leaders' mind in the health system on we have the right data analytics package moving. And then clinical integration. What is the relationship between supply chain and the clinical environments that are going to help you get there? The relationship is most important, and you develop the relationship by integrating your processes so one cannot do without the other, and you are no longer looking at supply chain in an OR and what we do in the clinical environment in an OR, but it really is an overall picture of end-to-end supply chain in a clinical area. And your nursing leaders need to buy into what this might look like and what supply chain does for them. And then automation. Once you have that clinical integration and the processes outlined, how do you make this faster and seamless, putting technology into the environment in the right way to be able to capture where you need to go? And so getting to level 7 requires hitting all 4 of these things. Next slide. All right, what is a supply chain infrastructure, right? What does it look like that you need to start thinking about building your vision and strategy around? And it really is the tracking and traceability of the products, the care processes, the teams involved together, and then linking that to the individual patient outcomes on the other side. And that's where the data comes in. And then taking a look at, when you have your data sets in your own health system, what can you provide on the outside to link it to that world of evidence and research that's going to drive larger patient population and outcome goals? Next slide. And this is one of Ann's slides that I kind of borrowed. I'm going to look at it from a little different perspective than supply chain, though. This is a very supply chain centered slide. And I'm going to talk about the clinical half of why this is important to us on our side. Because if we can't see value in what you're doing, becoming clinically integrated, no matter what tools you put in, no matter the great analytics, is not going to get that clinical side engaged. And so when you look at global standards of adoption, you look at using barcodes, G10s, to be able to trace products. Most clinicians and physicians don't get extremely excited about this unless you can link it to their practice and how they can help their patients. And so when nurses and doctors understand that point of use consumption, regardless of how you get it there, makes for a better workday, keeps that nurse by the bedside in an OR, being able to deliver products, and gives physicians data that they can trust on cost per case, linking quality outcomes, as well as improving their measures. That's what gets us engaged in this pursuit with you. And so traceability and recall becomes important to us because we want to know if we have items that we placed into patients that may need to come out. And that traceability and recall is also linked to being able to provide expiration dates of products and implants in a very automated fashion. And when you can provide that and prevent us from putting in products that are expired, you eliminate a lot of cost and just patient problems through the health system. And then taking a look at the transparency of patient care outcomes across that journey of care. You know, today, many health systems look at what we've implanted in an OR. We look at what we've done on a nursing floor. We look at items in a cath lab. But patients don't travel in a linear manner. Patients need care based on where they are, and we move patients around to different environments to get the care they need. And we want clinicians in each one of those environments to be able to see what was consumed and used in other environments in a very seamless way that tells the patient's story. And you absolutely cannot do this unless you're digitally enabled. And so that's the big sell for physicians and nurses in getting engaged in helping supply chain get to where supply chain needs to be. And then we talk about a personalized health system, right? That we want to be proactive in our delivery, right? Not just based on Mercy data, but based on data from across the country that's been aggregated to be able to help us tell the story on where we need to be. We also partner with vendors and manufacturers in a very specific way in Mercy because we can share data with them. Not only are we a good partner in being able to tell them how their devices or implants are performing, but we contribute to that body of knowledge because we are digitally enabled. And then you'll notice on the bottom has a little bit of that clinical side that we looked at, but without the data analytics to show you what your ROI is on performing in this manner, it's really hard to get that C-suite engaged. And then having the predictive tools to tell us where to move next. Not only tell us where we are today, but what do we need to do on that next step to make sure that we're ahead. For supply chain, we might say it's demand forecasting. On the clinical side, it's being proactive and having what we need for that patient when we need it. Next slide. And this speaks to the next piece of it, which is what does the data analytics look like? Moving in from 4 to 5 on that CISOM tool requires that you have the analytics to be able to get you there. And there are very few health systems today that have a good data set coming out of their automated system to be able to even tell them where they've been, let alone move into that predictive model. So if somebody said to me, Betty Jo, we need to be ready for the next pandemic, the next thing I would ask them is, tell me about the data that you produce, and then how can you turn it into information that's actionable and delivers a message not only to supply chain, but to the clinical side as well. And it should be the same data set. So you can see where Mercy is really on this generation is we have descriptive in a very automated format. We have predictive in an automated, mobily delivered, right on your smartphone. We're still working on prescriptive, right? On we know what we should do because we looked at the data, but we want the data to automatically tell us what to do. And that requires us moving into more of a mobile delivery platform for our entire analytic structure. And that's what's going to help us solidify into that stage 7 of the CISOM. And it's a pretty steep maturity curve for most health systems to be able to get there. And we have vendor partners that help us every day. We are on a platform. We use a couple different platforms, but our data architecture and data warehousing, putting all the data from all of our automated systems into kind of one data warehouse helps us slice that data to be able to get there. Next slide. So what does that high-performing data platform look like for us in Mercy? I have down here a couple of the big platforms that collect data for us, and we call those systems of record, and they're probably very familiar to you, but it's Epic, Kronos, our ERP is Lawson, and of course we have a couple of add-on systems that we use for performance. But it takes a look at some of that integrated data. How are we storing it, organizing it, and processing some of that data? And we use a couple of databases. It's Oracle, we use Hadoop, and we use HANA to move that data into that kind of state that we can slice and dice it for delivery. The next one over talks about how we serve not only supply chain, but the clinical side. And it is SAP is who we use for most of our enterprise analytics, and we use mobile BI from Microsoft for delivering it to smartphones to make the information actionable. And then we have some operating systems that we deliver things to, and then other analytic platforms that we use. But for me on the clinical side, what makes this completely actionable and information driven is that in-between database platform where we store our integrated data. That's one of the keys to success in any health system. Next slide. So I thought it would be most helpful, right? We've done a lot of talking about things you need to do, right? Like taking a look at what the vision down into strategy and to tactics might look at. But at this point, it would be very helpful for you to see how we're using the analytics and what we've done during this pandemic that allowed us to get there. So when COVID started to kind of surface on our radar screen late February, early March, we didn't have to change anything to get additional information. All we had to do was slice and dice it and deliver it into that mobile BI platform. And I think most of our senior C-suite leaders understood where we were on that CISOM kind of integration delivery staging method, but I don't think they understood the power during a pandemic on what we could produce. So one of the first things that our system CEO, Lynn Britton, asked us for was, can you tell us at that very highest level how much product we have? Not only was the question in our CSC or main storage area where we keep most of our supplies, but we needed to pull information from that CSC and each of our hospitals who had things stored individually, not only in the supply chain environment, but the clinical environment. And the only way to pull all your resources up to that system level is to be digitized in that space. And so we didn't have to do anything other than create a dashboard that said PP inventory. And the questions that were asked of us were, how many days are on hand by product category? So we chose, if you'll look at this dashboard, we chose to slice and dice it by our blue droplet mask, our exam gloves, which were, we knew we were going to burn through, our gowns, which if you're following today, there's a shortage of gowns, isolation masks, N95 masks were key in the beginning because the testing for COVID patients was so limited that patients that were coming through the door with any respiratory symptoms or answered yes to any of our questions, we literally had to treat them as COVID positive, and that requires having a large supply of N95 masks. And then, of course, face shields were key to us to preserve our N95 masks, and then the swabs, which were our rate limiting factor on being able to test patients. So these were the key things that we decided that we needed to look at. And so the things we wanted to know were current inventory, right, which would be what? Descriptive analytics. And it's very flat fashion. We pulled our descriptive analytics and said, across the entire system and every single nook and cranny, here's where we are on current inventory today. And then the projected velocity, right? What does that pull in for us? It pulls in that predictive model that said, if we continue to burn through these items at the rate we are today, here's how much that we're going to need to have, right? How much product are we going to need to have? And then it's your projected days on hand. So how many days on hand do we have today at the current burn rate? And you'll see a number to your left that says actual days on hand, and that's an aggregate roll-up. And then we're also able to predict by product category how many projected days we have on hand. And then what's our pipeline inventory? So pulling from all of our vendors and all of our sources, what have we been able to secure? What do we have moving? And what can we expect to come in based on shipping information? Again, entirely automated. And that pipeline inventory for me in my brain says this starts to cross over into that prescriptive model to tell us what to do. If we know how much we have coming in, we know how much more we need to source to keep up with it. And then our actual velocity, or our 7-day average, told us the direction we're moving, and whether you'll notice the arrows off to the right, pointing up means we're moving in a positive direction, and the red says there's some caution there, right? We might need to start sourcing a little bit of those things. And then the green shows you what direction things are moving and that we were okay. And then the overall percentage of projected velocity based on what we knew, taking CDC data, taking a look at projections that were coming in, we fed that through our analytics platform and said, based on what we're seeing, what should our percentage of projected velocity be? And then our actual days on hand are calculated. And of course, there's visuals below that people really like. And if this were in a live environment, I could hover over each of those points and I could see where we were on our actual velocity and then what we were projecting, even at that time period. So I can go back and check myself day by day to say, what were we predicting and did we hit it? And it allows us to refine our model. So that analytics keeps churning and we keep getting what we need. This one dashboard has saved us in Mercy. We never experienced a shortage of any of our products. We got low, right? But we knew then we had to shift our time and attention away from other products and start sourcing those products. And I've talked to many of my fellow CNOs across the country, and this is not how they had to work. They basically had to work and source everything all at once because they had no idea what they had on hand. They had no idea of their velocity, and so they were not able to target at certain periods of time what they should be focusing on. And what that does for Mercy, it puts us in a spot of not reacting, and we were first to source products, and so we got them, right? We were well established in what we needed before anybody even had a thought or had a good vision of what they needed in some other health systems. And some pretty big health systems, right? We're competing with the Mayos, the Intermountains, and this put us on the map because we were able to get there and get everything we needed faster than some health systems could figure out their data sets. Next slide. And then to get to that prescriptive predictive model, we were able to forecast, right? When you have that kind of delivery and consumption and you have a true perpetual inventory management system linked into your data analytics platform, it allows you to do inventory forecasts. And so not only we were looking at yesterday and today, but we were able to forecast the velocity, putting in some other data points that were coming from outside sources. Now, was it 100% correct? It wasn't, but we erred on the side of having what we need. And to be honest with you, we've been through our first wave in Mercy of COVID. And it's interesting, it started east and now it's shifting west. So our more eastern hospitals, our St. Louis hospitals, were hit with a surge about 4 weeks ago. And now we're starting to move more west, and our Arkansas hospitals, and we're looking at our Oklahoma hospitals, which we believe may be next. We're able to move inventory to where we need it. So if we kept all of our swabs up to where we needed it, we're able now to move the swabs from St. Louis into Arkansas, which their velocity of swabs and PPE is going up right now. So we're able to move that inventory as well as keep our demand forecast moving forward. There's no better comfort for a nurse, which I am, than to know that my 15,000 nurses and clinical coworkers across Mercy have what they need to take care of these patients, and I'm keeping them safe. And I can say that with a high degree of comfort and actually publish this data so my nurses know not only am I saying it, but I have the data and the backup, and they're seeing it in their hospitals. There's not a day that they did not have what they needed to take care of patients. And that's equally true for my Arkansas hospitals that are going through it now. And so we have lessons learned that we learned in St. Louis, and now we're transferring all that to Arkansas. So we have strict PPE protocols. We have policies developed to where we're checking to make sure that the clinical team has what they need and that they are still preserving PPE the way we started in the beginning. And so our supply chain's able to have exactly what they need and deliver it to each unit to make sure that we're keeping a check on the inventory that we're delivering out. Next slide. So moving away from that data analytics platform, but before I do, I want to make sure that you understand that the power of information either makes you completely able to take care of your patients or leaves you scrambling on the back half for keeping your coworkers safe and really your other patients safe. So the other patients that are in the hospital at the time of COVID can feel certain that our coworkers are protected so we're not spreading things to a population that didn't already have it. But that clinical integration becomes important not only in the time of a pandemic, but it's important that it's established ahead of time because, as you know, as we're heading through this pandemic, you're probably not going to establish a whole lot of things that you didn't have in place before. You're going to be more reactionary rather than take advantage of that infrastructure that you've built. The CISOM tool, flat when you look at it, is a lot of process things that you need to address. But if you address those process things in the right way, the people come right along with it and build the infrastructure of the leadership team, the clinical coworkers. It kind of creates that platform that gives them exactly what they need to work together in a relationship pattern that allows clinically integrated supply chain to flourish. And that's really what, when we say clinical integration, we're talking about. So what does that path of partnership look like moving forward? Why would somebody even want to use the CISOM tool, right? What does it give you other than information about where you are today? It gives you that path forward for structure, people, process, solutions, which I'm going to include technology and analytics underneath there, and then that accountability to make sure that your health system can actually deliver on what you're promising. With a high degree of certainty, I can look at everybody in our communities and say, Mercy's ready for this pandemic. We have exactly what we need, and if we don't, we know it ahead of time, and we will source it and get it. First of all, supply chain has to be a key partner in this. And so I would say that most people, when you look at manufacturers and vendors, have more access to the supply chain side than they do the clinical side, which means that you're focusing on that supply chain side most of the time. But where you run into trouble with products or analytics or feedback on your product is access to that clinical side, because supply chain doesn't always have the best partnership with us unless you have a platform that we're moving forward together. So the value of creating or getting to that level 7 is that it literally becomes seamless on that vendor or manufacturer side for helping us get the right products for our patients. And it really shouldn't be about selling things to us. It really should be about understanding the data together with us to be able to help us buy the best product. I am more than willing with my trusted partners to pay more for an implant or a product if I have measurable outcomes that prevents one more surgery, that prevents me spending more money in other product lines to overcome something that wasn't delivered with the supplies and implants that you sold us. And so with data comes that realization on the clinical side that it's much more than just cost, right? And I want to partner with people that want to look at things in that way. And also help manufacturers develop things that we need, not things that you're thinking about out there we might need and you want to sell, but literally we do it together with the data set to be able to help inform where we're moving with our individualized patients and patient populations. And then supply chain is a clinical partner for us. They are a strategic partner, and I could not do my job without them. They give me the technology and the analytics I need to make good decisions on the patient care side, as well as make sure that my nurses, my physicians, everybody on that clinical side has the same information as I have. And so what does that unique collaboration look like on a contracting strategy when you have data? It's seamless. I mean, no longer are you convincing us about your data on the manufacturing side and clinical outcomes. I have my own data to be able to prove it. So if I'm sitting with one of my trusted partners and we're talking about, say, a new implant that's coming out, we'll look at data on the old set of implants that we have and say, where do we want to improve? What does it need to look like, and what are we trying to drive? But supply chain, the clinical side, and the manufacturing side all look at the same data set. So when we do contracting decisions in Mercy, my contracting decisions are not based off of purchasing data. They're based off of utilization data. So I can tell what the physicians are using. We try to reduce variation in that product line, which allows for a better contracting strategy, because I can convince surgeons and physicians that some products are better than others based on the data and the outcomes that we have. And that's a much easier conversation than just saying, hey, this is a cheaper implant, we're going to standardize to it, right? They are concerned about their outcomes because it is their quality of data and their reputation on the line. And so it becomes a whole different strategy when you look at the same set of analytics in the same way. And then it also allows us as partners to do risk sharing across service lines. And so no longer do I look at a product in cardiology or look at it in the OR. It's literally across the service line. And the data sets may prove out that it's better in a certain patient population, and that population occurs in the cath lab. But when you switch over to the OR for whatever reason, we can take a look at variation and what products need to occur when a surgeon has it in their hands and when a cardiologist has it in their hands. That outcome data may look totally different, or it may not, and we want to contract across all service lines. So it really is getting to that, what Ann talked about in the beginning, that personalized patient experience and delivery. That's what allows you to get there. And then proven value, right? It's more than cost savings. I want to know what kind of outcomes we're driving together as partners and that value across the entire portfolio of business for me. With appropriate technology development, I may be willing to take newer technology and pay for it if I can prove where we're heading, and then we can measure the data against whatever outcome we're trying to prove. And it allows me just to partner differently. I usually don't entertain just manufacturers with one-off on things in Mercy. I try to go with my trusted partners and develop things or look at things in a way that will make us both successful. The biggest example I can think of that is I'm digitizing my ORs right now, meaning trying to get ready for what a virtual rep experience may look like. And there's a ton of products out there you could choose. I'm engaging with some of my manufacturing partners together to take a look at what's going to benefit them as well as myself, so we can leverage getting the best reps in even some of our rural hospitals through a virtual capability component, which is less cost for the manufacturer. So that's what being a good partner does, and allow you to move forward together. I'm not just putting technology in that I'm expecting them to use, but we're looking at the technology together to make sure that it's going to meet the patient's needs, the surgeon's needs, as well as the manufacturing needs. And then problem solving together, right? If I have a problem that I can't solve, or the data is showing me something that I'm at least is an outlier, I have partners that I can take a look at outside data with them and take a look at that real world evidence and see if Mercy is just an outlier there. The last thing I want to say on this slide is focusing on the order of people, structure, process, and technology. You notice that process and technology are at the end of the line. Getting that right structure and the people aligned on the supply chain side, the clinical side, the decision-making side is key before you start touching process and technology. And this whole demonstration of the pandemic has really shown that Mercy investing in making sure we had the pieces and we're at level 7 on the CISOM tool really lines all of that up for us to be able to drop in process and technology to drive better outcomes. Next slide. So I put this in here because I like this slide that kind of pulls in clinically integrated supply chain, driving transparency of that real world data and evidence off of value and performance in my health system. I like the way the ERP and the EMR kind of give you that integrated data set that we feed into an analytics engine, right, into that structured platform piece that allows us to come out on the other side on the predictive analytics. I'm really working hard to get to prescriptive analytics. It's really on my radar screen as soon as I get past some of these COVID surges to try to be able to complete that level 7 of the CISOM tool and go back and make sure that I'm firing still on all the other levels is going to be key. Next slide. Automation methodology. We use, and I wanted to give you an example, some Six Sigma principles, which are probably not new to anybody here, but how you take those principles into supply chain, if you'll just click forward, I think that'll show us another example about one more time, moving those principles into what it looks like in an integrated supply chain model, right? So a lot of people have a hard time taking those principles and putting them into spaces to drive action. It really is all about, for us, driving inventory accuracy. I want to know at any point in time what I have everywhere across my health system, not just sitting in a warehouse that I'm counting. I want to drive that productivity and accountability from the supply chain perspective and the clinical perspective. A lot of times in the clinical environment, we push on supply chain to deliver things that are unrealistic. And if you talk to my supply chain partners, I am very careful about not doing that until I have the data to be able to go back and say, no, we had trouble here. Here's where we need to improve. It's not supply chain and clinical. Of course, eliminating waste and extra touch points. When you're fully automated and have the data, you do less cycle counting. You know the day's inventory you have on hand. It's an aligned contracting structure. It's a procurement model that makes sense and is very targeted. And to be honest with you, allows you to have less people in the mix when the technology drives where you should be. And then expand services into critical areas. So if there's something we're not covering today, all I have to do is move that thinking into that area and put it within the platform that I'm currently functioning on. And then match labor to demand schedule. So it's interesting the amount of clinical knowledge you can get out of a supply chain system. For example, in my ORs, I'm able to see by the number of lines picked, by day of week and number of add-on cases, how efficient my OR staff is booking cases, getting the preference cards over to supply chain to pick. I'm able to see what I can do to help them and then what my efforts are driving for them, and then hold them accountable if it's something on their side of not having the product available for our patients. So it just clears up all those misconceptions and fighting that usually goes on between supply chain and the clinical side. And then avoids the request to increase labor. So if I am running behind or can't deliver on something from the supply chain side or the clinical side, I don't automatically go to the labor issue. I go to the technology and the analytics to show me what to tweak, move, or adjust on the clinical side or the supply chain side to make it happen. Because at the end of the day, for me, it's all about the patient. And at the end of the day, for my supply chain partners, it's still all about the patient. And so we have a common goal towards serving our community, our patients, in the best way that we can. And Mercy has shown up very well during this pandemic. We, with a high degree of certainty, deliver the best care in our markets. We have exactly what we need to be able to do it. Next slide. And so a little bit, this slide just really talks about what we've been talking about throughout the whole presentation. If the quadruple aim is exactly where we should be, we want that automated flow of data at the point of care that informs the physician's or clinician's practice, whether it's a nurse or a physician. We want them to have that improved experience of having information they need to take care of the patient without either having to run out of the room, search for it, or dig through Epic or another system to be able to find a cost of a supply. Improved patient outcomes is always the goal, obviously, and we want to participate in what that looks like outside of our health system, as well as inside our walls. And then that improved patient experience, we want to link all of our data to outcomes, which provides an improved patient experience. It may be shortening our OR time, it may be keeping on time in the surgical department, it may be length of stay for a patient, and being able to transfer them to a different level of care faster, and get them into an environment where they're more comfortable, right? Even with our virtual care, it allows us to move people out of the hospital environment in a much faster way, putting them back at home with their loved ones. But they have that daily connection with a provider, so they're not searching for somebody to ask questions to. And we're keeping our eyes on all of their data sets as well, and feeding that back into our analytics platform to tell us if we made the right decision in moving them to a different level of care. And then the lower cost of care, automation of the work processes, it reduces labor costs, it reduces supply waste. We only buy what we need, and we buy what's most effective, right? Which allows us both together, the manufacturing side and the hospital side, to be more productive. Next slide. So how do you know it's working in Mercy here? For a little bit of a wrap up here in our last couple of minutes. What have we done with our CISOM score? And you know, I'm very well aware that I'm not quite through level 7, but I have to get there. And it has less to do with the tool, guys. Has less to do with the tool and more about creating the right structure in your health system to be able to make decisions, right? And combined with the manufacturing side and the supply chain side to say, are we all looking at this through the eyes of the patient? It's just a clear understanding of what clinically integrated supply chain infrastructure, that maturity plan, what it needs to look like. So regardless of where you start, right, you know where you need to go next and the next step and the next step to be able to get there. And so what does it deliver at the end of the day? It gives us, I put some numbers here on what we've been able to save over the last 5 fiscal years. It's driven cost savings, which always gets the attention, right, of everybody, and that's why, of course, I put it on there. But when you look at our quality outcomes and our safety, we are an IBM Watson top award winner for a health system. 5 years in a row, we've won this award. And it is very hard to get this award, not because you have to hit a certain benchmark, because you have to show a continual rate of performance year after year. You have to get better and better. You can't just stay the same, right? And so having that, being all leapfrog A's with one leapfrog B across our whole system, that's how we measure ourselves at the higher level, right there with the money that we're saving as we're doing it. That is the quadruple aim, right? In its largest format, that's exactly what you want to see out of a health system. It will not occur without having the supply chain and digital infrastructure to be able to make good decisions. The naked eye literally cannot consume that much information and give a good direction for a health system without it. So while I love the CISOM tool, the reason that I like it is because it helps me know where I am on that roadmap. And so any of the manufacturers that deal with Mercy know that we have more data than any other health system and that it's accurate because we collect it at the point of care. We don't connect it through putting it in on the back half and hoping it's right. It's literally delivered with what we're using right there at the patient level. Next slide. And so,
okay, well, thank you so much.
I've been talking a ton, but I don't know if there's anything for wrap up.
I'm going to hand it back to Samantha. Thank you ever so much, Betty Jo. If ever there was a time where you delivered the insights and the value of clinically integrated outcomes and the digital health infrastructure more broadly, this would be it. So thank you ever so much. And Samantha, over to you.
Thank you so much. We will be sending out a copy of this slide deck as well as the recording of the presentation after this. And if you have any questions, please email customerservice@himssanalytics.org and we will answer those questions for you. Thank you so much, Betty Jo.
Thank you, guys.
Thank you, everybody, for joining us today.